Welcome, everybody. I'm Rob Olmer, Dean of the Greenspun College of Urban Affairs. It's really great to have you here at Greenspun Hall. Sweltering day, so if you like that, you're at the right place. We also, just to give you a feeling of kind of environmental justice a little bit, we've cut the AC. So Arash is, he's not sweating because he's nervous. He is sweating because it is a little bit warm in here. But hot topic, exciting topic, really, really important topic that we have today for you. Great panelists, and so thank you for taking some time out of your day to come to Greenspun Hall, UNLV, Greenspun College of Urban Affairs, and I'd like to introduce my friend, the CEO of Nevada Partnership for Homeless Youth, Arash Ghafouri. Please, a warm, hot welcome for Arash.
Thank you, Rob, for that warm introduction, and thank you all for being here today. And Rob, thank you for the cover on the sweat. You know, I didn't want people to think I'm nervous just doing introduction, but thank you, like a diamond, I hope. Well, anyway, welcome to the Movement Institute Volume 3, Mental Health. My name is Arash Ghafouri, CEO of Nevada Partnership for Homeless Youth, and I want to thank you all, first and foremost, for taking the time to be here today. Thank you to our sponsors, Las Vegas Sands and UNLV Greenspun, for making this event possible today. So the Movement Institute was introduced at the November 2022 Southern Nevada Youth Homelessness Summit presented by NPHY and Sands Cares. This innovative hands-on advocacy training is designed to educate and create community champions, all of you, to be the movement to end youth homelessness by learning about youth homelessness's root causes, policy, systems intersectionality, funding solutions, and more. The November 2022 Movement Institute Volume 1, Advocacy, focused on introducing the issue of youth homelessness and how community members can become advocates. And then in March of this year, we hosted the Movement Institute Volume 2, Policy, which focused on the legislative process and how policy can impact the homelessness sector. As many of you already know, there's been a lot of buzz about how the pandemic has impacted mental health. According to the National Institute of Health, rates of anxiety, depression, and substance abuse disorders have increased significantly since the beginning of the pandemic. For those with developing brains, the impacts of the pandemic are not yet fully understood. What we do know is that there have been many things that may have influenced the cognitive, social, and emotional development of young people during the pandemic, including an increase in isolation and loneliness, changes to their routine, virtual schooling, mask wearing, caregiver absence or loss, financial instability, etc. So today we are here to discuss how these and other factors are exacerbated among some of our most vulnerable youth experiencing homelessness. As youth homeless providers, we have seen a substantial increase in severe mental health issues among the youth we serve over the last several years. We must explore the homeless service sector. We must explore how it is struggling to respond to the increased needs as we are not equipped to deal with the severe high acuity mental health needs. As a community, we can come together in collaboration with the mental health services sector to support each other in these challenges we are experiencing in order to better serve our most vulnerable youth. So that's why we're here today. I'd like to introduce Dr. Nicholas Barr, Assistant Professor at University of Nevada, Las Vegas School of Social Work. Dr. Barr is an Assistant Professor at UNLV. He received his BA in Comparative Religion from Columbia University. Many of you are probably familiar with this bio already, where he studied Tibetan Buddhist philosophy. As a Princeton and Asia Fellow, he worked in education and development in Laos before earning his Master's in Social Work with a concentration in adult mental health from UCLA. He then worked as a clinical social worker for the Los Angeles County Department of Mental Health before completing his PhD at the University of Southern California School of Social Work. Dr. Barr's research focuses on improving understanding of risk and protective factors for populations with an elevated likelihood of traumatic experiences. Very fitting for the population we're discussing today, homeless young adults, and he also works with military service members as well. And with that, I'd like to turn it over to Dr. Barr and our esteemed panelists. Thank you all for being here today. Dr. Barr is going to introduce you and get the show started. Thank you.
Well, thank you very much, Rob and Arash, for organizing this spectacular panel, and thank you to all of you for being here to talk about this critical intersection of these two really important issues nationally and in our community here. and those issues are youth homelessness and mental health. So we have really just an excellent panel today, and it's my great pleasure to introduce them. So this is in alphabetical order. First, we have Vanessa Donzi, who holds a master's degree in physics and chemistry and is a current Doctor of Nursing practice student. She is the Director of Adult Crisis and Mobile Response at the Human Behavior Institute, where she's worked for the past 10 years. Human Behavior Institute, HBI, established a crisis stabilization unit in 2015, and this is an intermediate intensive therapeutic treatment for adults between the ages of 18 and older who are experiencing a level of emotional distress, crisis, or other symptoms that would place them at risk for inpatient psychiatric hospitalization. She's originally from Portugal, where mental health and substance use treatment and homelessness look very different, and part of her aspiration is to bring a bit of Portugal here to Las Vegas, which I, for one, would certainly be open to. Dr. Lisa Durrett is an assistant professor, Child and Adolescent Psychiatry Fellowship Program Director, and interim chair of the Department of Psychiatry and Behavioral Health at UNLV. She graduated from the University of South Carolina School of Medicine and completed both a general psychiatry residency and a child and adolescent psychiatry fellowship at the Medical University of South Carolina. She is board certified in general psychiatry and child and adolescent psychiatry by the American Board of Psychiatry and Neurology, as well as in addiction medicine by the American Board of Preventive Medicine. Dr. Durrett is a distinguished fellow of both the American Academy of Child and Adolescent Psychiatry and the American Psychiatric Association, and spearheaded Southern Nevada's first Child and Adolescent Psychiatry Fellowship, where she serves as program director. Richard Espinoza is the director of programs at the Nevada Partnership for Homeless Youth, where he leads and oversees NPHY's wraparound programs for young people experiencing homelessness. Richard holds an MS with a concentration in forensic psychology from Argosy University and a BA in psychology from the University of Nevada, Las Vegas. Prior to joining NPHY in September of 2020, Richard worked with underserved youth as a therapist, substance abuse counselor, and case manager. Richard has extensive experience working with vulnerable young people, previously worked with populations including foster youth, youth involved in the juvenile justice system, children with disabilities, and homeless young people. And before becoming NPHY's Director of Programs, he served as NPHY's Housing Programs Manager, supervising their independent living, transitional housing, and rapid rehousing programs. Kim Moore has a Bachelor of Science Human Services degree with over 20 years of experience working with people dealing with substance use disorders and 15 years working with homeless youth. Since 2017, Kim has been the director of Shannon West Homeless Youth Center, working with the hardest to serve youth in the community. Kim's experience includes homeless youth shelter management, solution-focused techniques, evidence-based practices, grants management, audit compliance, trauma-informed care practices, mental health first aid, housing first harm reduction, low barrier shelter practices, and staff training and supervision. Kim participates in various community working groups such as the Southern Nevada Youth Working Group, the Southern Nevada Emergency Shelter Leadership Group, the Point in Time Homeless Census, and many other working groups centered around homelessness. Finally, we have my good friend and colleague, Dr. Robin Petering, who is the founder and CEO of LensCo. Robin has worked in the field of youth homelessness since 2008, starting as a street outreach worker in Oregon, and then receiving her master's and doctorate in social work in Los Angeles at UCLA and USC. We did both our master's and PhDs together, so go Trojans and go Bruins. Dr. Petering's academic research focuses on the impacts of the experience of homelessness on young people and how to prevent homelessness through innovative policy and program implementation. In 2018, she founded the organization LensCo as a way to bridge the gap between community advocacy and data-driven research. So can we have a hand for our fantastic panelists, please? It's a lot of brain power up here. So maybe to begin, just sort of setting the stage, and this is open to anyone who would like to jump in, could we talk a little bit about who youth experiencing homelessness are and what some of their unique characteristics are, and perhaps what recent changes you've seen regarding the mental health needs of this population?
So who are homeless youth? So, oh, there she goes. She's jumping at me in the bag. So homeless youth in our city may or may not look different. Homeless youth are, they could be youth that were kicked out of their houses, for misbehaving, youth that left their houses because their parents were not stable, youth that need support, youth that are in school. It's hard to put a specific category on who they are or what their unique characters are. A lot of them have some trauma, a lot of them have not had the best, childhood, what they all have in common is they all want to succeed somehow, some way. They want to have their own place. They want to work. They want to have a family. They just want to blend in with society. I'm looking for her jumping at me. It's hard to say that they may or may not. Some of them have the same characteristics. Some of them have different characteristics. And then, so what was the, okay. Anybody else? Oh, come on, Richard.
Thank you, Kim. Yes, to piggyback on what Kim was saying, they are kind of an invisible population. Sometimes they're among us and we don't even realize it, or we don't know that, they might need some assistance or help. And it takes, a lot from them to kind of initiate that, search for the help, or to take that first step towards, reaching out, bettering themselves, or looking for something to stabilize them, because they're not aware of services that are available to them or what assistance can be provided to them depending on their dynamic or ever evolving circumstances daily. So, yeah.
I think one of the unique characteristics of young homeless is the fact that they have no vocational training. So when you have people who are older, they've at least tried working certain jobs, but when they're really young, they have no training. They've never had a job. They're not able to just go out there and start something. Hello? Okay. And just go in in work. So they have to have training. There's a lot more, I think, hand-holding with a young adult than maybe an older person. So I think that's one of the things. And another, I think, characteristic with them would be they usually if they end up homeless, it just happened that they broke off the relationship with their families. So it's very new to them. So when it's an older adult that is homeless, that probably has been a longer time now, that it makes it better, but it's not as fresh. So they're not dealing with the emotions of that as well. So.
Okay, I'll hop in. So we were just talking about this too. Often when we think about young people experiencing homelessness, I often think about, it's young people that have a lack of a safety net, stability, and support, right? And so the difference between experiencing homelessness and maybe not, I'm often thinking about stability and safety, both emotional, mental, physical, all of those things. And often, the differences individually between a young person that's housed and not are really the access to those resources and a safety net, right? So we talk about young people out on this campus in college, right, are experiencing mental health crises. They're using drugs. They're kind of living their young life, but with access and potentially the safety net essentially for folks and versus not. So that's often how I think about kind of the dichotomy of unhoused versus not. And then, really just also putting out there that this is the systemic factors too, right? So predominantly young people of color, really high rates of LGBTQ and gender nonconforming for a lot of, we can get into the systemic issues later, but also wanted to name that, put that. A lot of young parents is also really common as well. And yeah, economic factors, all that stuff.
And so I think my colleagues have all, nailed a really good description of the fact that youth who are homeless, and when I say youth, as a child and adolescent psychiatrist, I include youth going up to 25, our transitional age youth, because really, what is magical about 25 versus 24 versus 18? We know that at a neurologic level, our prefrontal cortex and our ability to have strong functional reasoning isn't even solidified until our mid-20s. So in including this concept of up to the mid-20s, what are some of the risk factors that we've talked about that are inherent in the youth that experience homelessness? So youth in the foster care system. This is an area where I do a lot of my work. So kids who grow up in the foster care system will turn 18, and then what? And so for a lot of these youth, there's not a then what. And they are gonna be at a much higher risk of going into the homeless youth system than their cohort that are not in the foster care system. The same goes for kids who are heavily involved in the juvenile justice system, the correction system. They are gonna be at higher risk. And our youth with psychiatric illness. So I think, Dr. Barr, you started talking about it a bit. What are some of the factors about mental illness that are different today than there were 5 some odd years ago? So now the average prevalence rate for mental health problems in youth, and again, I'm now gonna talk about 18 and under, looking at just the way the data was done, is about 1 in 5, 20% of youth. That had always been the prevalence rate. And more recently, groups like SAMHSA, the Substance Abuse and Mental Health Service Organization, agency, and other national agencies like the CDC have put forth prevalence data that have shown our rates of depression, rates of suicide attempts, suicide gesture, rates of substance use disorder in youth have risen higher than 1 in 5. And our kids who have unidentified mental illness, untreated or inadequately treated mental illness are gonna be at higher risk for experiencing homelessness. And I think we're gonna end up getting to that in some of our later questions about what can be done.
Yeah, thank you. Those are really thought-provoking and interesting answers. It also, I think what we're hearing is that there is sort of an intersectional profile of risk where you have youth and young adults who may have a mental health problem, but then that intersects with these other dimensions, and that might be, vulnerability because of race, gender, ethnicity, immigration status, economic availability of resources, things like that, and that perhaps we're seeing an exacerbation of those mental health problems in relation to those other vulnerabilities. So maybe we can consider now what barriers and challenges youth with high acuity mental health needs face when trying to access services in the youth homelessness system here. So in other words, how are some of these higher levels of acuity or intensity around mental health need impacting youth's matriculation through the homeless services system?
This is my soapbox. So just some background on how the homeless system is set up is that in the homeless system, we are supposed to be rare, one time, and brief. And so what has been happening over the last several years is that those benchmarks are becoming more and more challenging because of the severity that we're seeing. So at the Shannon West Homeless Youth Center last year, 63% of our population had pretty severe mental health issues. And so when we talk about an individual coming in with a diagnosis such as schizophrenia and they're unmedicated and they don't want to acknowledge that there may or may not be some mental health issues, we're not set up for that. We do the best that we can. We take them to the psychiatrist. We get them on medication if they choose. If they don't want medication, we're not going to force them. and then it comes time to, okay, you're stable. We're gonna, get you into with another provider. And this is a real story. I had a youth that was schizophrenic, and he got his own apartment and supported within the community. Well, he stopped taking his medication and he left his own apartment. He was street homeless again because he was better. He didn't need his medication anymore. And so we don't have, I have one therapist for 150 youth on site. And so that's a little overwhelming for one therapist to see all those individuals per week. We don't do takedown holds. We move. And so if one of our individuals are becoming violent, we move. We're not set up. We train our staff the best that we can within our constraints, but our priority is homelessness. And so we need some resources. We need, some support from, the other systems. It takes me 18 months to get an individual with developmental disabilities into the appropriate system. That's a long time to leave someone in the homeless system. It's not rare. It's not brief. It's not one time. Okay, there's mine.
And to add on to what you were saying, our system is broken, and we have to acknowledge that. National rankings put Nevada consistently at the bottom for mental health metrics. So it's not just an issue about psychiatry, psychology, psychotherapy. We are lacking providers everywhere. HRSA puts almost the entire state, except for like 2 tiny zip codes up in Summerlin, as a mental health profession shortage area. And when we look at what's available in our system, we are pretty good on the crisis side. We have crisis centers, we can take somebody to the emergency room, and we have psychiatric hospitals. And then we have people that do outpatient practice. And then there's a bunch of tumbleweeds in between. And we know that in places, and LA's got more resources certainly than we do, but in well-resourced areas, there is a true continuum of care that starts at respite that can help mitigate and prevent homelessness, to acute crisis services if and when needed, to maybe long-term crisis respite to help somebody resolve an issue. You might have an intensive outpatient service where people can get care a couple times a week and they have some resources and they're getting their mental health needs met, to a partial hospitalization where they might come in 5 days a week and go back somewhere to their home and get care, to acute short-term psychiatric care to residential. That's a true continuum of care. And in a true continuum of care, it's a hard word to say, the professionals all communicate to each other. Like how exotic is that for the psychiatrist and the therapist and their counselor in their homeless shelter and their pediatrician or their internal medicine doctor, for all of us to talk on the best interest of our patient. That seems really logical. Our system is not set up for that. And there's some structural barriers within Medicaid and insurances. Insurance doesn't reimburse for that. Our insurance system is set up for a fee-for-service. You get this done here, this done here, this done here. Is not currently set up to pay for quality or outcome measures. It's not set up to pay for interdisciplinary coordination, and those we know from other states that have done this well are the keys to success. Having a full spectrum of care and having interprofessional collaboration where people are working on behalf of their patients.
So yeah, I'm not in direct services as much, but one of the things thinking about kind of folks with high mental health needs, what we're seeing in LA is, I know it's crazy to hear someone say that we have tons of resources, and I'm like, we definitely have a lot of stuff going on for sure, but still it's not enough. So I don't know if you all are aware, we've been in the past, so post-COVID, there's kind of large-scale efforts, and they're continuing to do it to take people inside, kind of like addressing large encampments and bringing them inside rapidly. There's a lot of different names for what happens in that, and they're there was 100 people living on Venice Beach, right? And they had like they're like, we're gonna get everyone off Venice Beach post-COVID. And they're going out there with daily case management, all this stuff, and they're opening up all these housing resources, primarily hotels and motels, which is a big, kind of new thing post-COVID that came online, which is a great resource. And there's 100 people on Venice Beach, and 80 folks went inside. And then after all that, like 6 weeks of intensive care, and you got 80 folks inside, and that's a huge success. But then there's 20 people left, right? And there's someone that didn't want to go to a hotel because they were having their severe hallucinations. There's spiders climbing on the wall inside the hotel. And then there's another person that was having, severe like substance use issues, right? So those high acuity, they're left. And then it's connect them to Department of Mental Health, and they get on a 4-week waiting list for an intake, it's just not going to happen. And that's 9 to 5. We don't have an emergency crisis response. Our primary mental health crisis responders are law enforcement in LA. And there's one mental health crisis van per county, maybe if you can get a hold of it, right? So it just that there's such a gap. And now what we're seeing, what's left is there's just the need and the vulnerability is left on the street, and they're the most visible, and they're the most disconnected and the hardest to engage with, and we just do not have the resources or the response system for it. Yeah.
Okay, so I'll share, I know we're not in Portugal, but I'll share one of the things, she mentioned that they place somebody in housing and then they stop taking their medication. One of the things that is implemented in Portugal is if someone is on an LAI, what ends up happening is they have a system in place.
Tell us what an LAI is.
It's like a long-acting injectable. Okay. So what happens is they have a van that actually goes into the community, and several vans, but they have a team like a doctor, a nurse, and actually the police also goes. And if anybody is on a LAI, what they do is they just go to the person's house and give them the LAI. So when the person initially meets with a psychiatrist, that is a consent that they sign. So before it's due, they actually go to the person's home and do those things. So I feel like it really does help with the person staying on medication and, being compliant with medication. That's one thing. And then another thing that Kim also mentioned was, just having a lot of homeless youth and not probably enough people to help, I think us all being here, we've shared prior to the panel that a lot of the people that she has are Medicaid clients. So I think just getting the community involved to help even with case management or with medication or with therapy. You said you had one therapist that works, if we can help with anything, HBI can help, or even reaching out to the health plan. I feel like we work very closely with Blue Cross Blue Shield. They're very, very helpful. I feel like they go above and beyond for their clients. I know, Lisa, you shared that some of the things that we need to be reimbursed are not reimbursed. I feel like some health plans do go above and beyond, and we do have a partnership with Blue Cross Blue Shield where we do provide housing for their clients. Of course, housing is not a benefit that is covered, and we know through the health plan, but they go above and beyond for their clients. Molina also provides that for their clients. So I feel like maybe just reaching out to the health plan, maybe knowing who to reach out to. It's not just reaching out, because if you're just going to the line, maybe they don't even know, like a regular caseworker with the health plan would not know. But creating those relationships where, maybe some clients we can help, because Kim shared that a lot of the people are Medicaid. So just knowing who to reach out to, So HBI can help, Blue Cross can help, Molina can help. Just maybe knowing who to reach out to. I think that's part of it.
Everything that everyone said here was spot on. Maybe just another layer to that would be kind of, incorporating that at the programs level too. When we talk about the case management and the client engagement, as soon as they start walking through those doors, that is also where they need to be the the person that they can trust, and then that advocate also to make those connections and collaborate amongst the community providers and be asking those questions on behalf of the clients to get those services that they so desperately need.
So maybe kind of branching out from this a little bit, it sounds like both there is a real deficit in terms of continuity of care or continuum of care, where we can see someone, help them go from a crisis through stabilization to the appropriate housing service to perhaps something like a training or education that allows them to be kind of successful as they move out of those services. So that seems like one deficit. Another is certainly just the availability of crisis response, right, to work effectively with folks who have really high mental health need. I wonder if for maybe some of the other housing providers, so, given that we have the queue, right, the housing queue, which is essentially the list of who is going to get prioritized for housing, and that's based on acuity. So, and please correct me if I'm wrong, but my understanding is it's based on acuity, so that people who have a more severe need, are totally unsheltered with a high degree of mental health acuity are going to be moved up that queue, right? And of course, a consequence of that is that other folks will be pushed down the queue. So can we try to understand a little bit of, how is it that this influx of higher mental health need affects your ability to serve the overall mix of youth experiencing homelessness?
So when we do the housing assessment for our youth and they score really high, they tend to get housing first. And so what I think we need to look at is what is appropriate housing for that individual. So some of our housing programs may not be a good fit. So somebody that belongs, that has some developmental disabilities, they may be higher acuity, they may get pulled first, but is that the appropriate type of housing for them? And so what happens is our youth that may be in the middle or not as high needs, they have to stay in the shelter longer, or they have to stay, in transitional. And so what happens is we expect them to self-resolve. And so those are the people that kind of get, I wouldn't say forgotten, but kind of, pushed down to the bottom. And that is who our housing solutions may assist the most. So at Shannon West, we have what's called transitional housing, and they can stay in that housing for up to 2 years. What happens is somebody that is higher acuity gets pulled for that, placed in that bed, and then is that the appropriate, are they gonna be ready to go in 2 years? Are they capable of working? Can they increase their education? And where do they go after their time limit? If somebody, let's say, hasn't been approved yet for Social Security income, or maybe their housing in the developmental system isn't ready yet. And so that's kind of the struggle that we have is this an appropriate housing placement for somebody super high on the list?
Yeah, I was just going to add too, like thinking about this, the queue, right? The queue and the QD scores and the matching and allocation system. So to take it back though, right? So the vulnerability scores, like, I don't know how long ago they were designed, right? So years, 10 decades ago, I don't know, whenever I started, someone realized that the most vulnerable people, right, they cost the system and our city, everything, so much money, right? And so by actually taking our most vulnerable, identifying like our highest systems cost users is actually cheaper to put them in. It costs $1 million to keep someone unhoused with all the emergency crisis interactions, the law enforcement interactions, and in and out of shelters and things like that. For $400,000 a year, we can permanently house them with wraparound care. So that was the idea, and that's where housing first came from. And so they're like, let's design a scoring system so we can identify folks to take the highest needs off the streets, put them in housing. So that's where the system was designed. But now flash forward 20 years, right? We don't have, we have this tool in the system, but we don't have the resources or the things to allocate what it was designed for. So now it just doesn't work, right? So these tools are designed to allocate resources best, but we don't have enough resources. And when you don't have enough resources to do that, it all falls apart. And so we see people not getting placed into housing that is appropriate for them. So, and then we see people that are ready for housing that are waiting now below on queues and they can't get into a bed that's available that would work for them because of this scoring system. And I don't know, communities have been trying to redesign it continuously. I've been on several projects that look into redesigning the scoring system, and we're never gonna get there. And I don't know, just going back into a more, what's actually happening too, people are just placing folks based on individual case by case basis, right? What we hear is case managers kind of going through the scoring system. And I've heard case managers just saying that they kind of back score people. They find, okay, here's a young person that's ready. Here's a housing and placement that's ready that I think is going to work for them. I'm going to put them into it. And then later I'm going to score them and make sure that they fit. Like that's what people are doing in LA, which is, it's just a perfect example of why these systems are broken and how they're not working, right?
Yeah, I think the analogy that I really liked, we were talking at lunch, is that, we're spending a lot of time and effort trying to find the perfect system to reorganize an empty refrigerator, but there's no system that allows you to organize an empty refrigerator to feed hungry people. That's not, where the emphasis needs to be. Well, I think, now that we have identified some problems, I think maybe one of the things we wanted to get into as well is where have we seen kind of creative solutions or other approaches be effective? And that might be, I think certainly Robin can speak to your experience at LensCo, where you've hired a number of formerly homeless youth, and maybe some of our other kind of provider side folks can speak to, what have you seen work with high acuity youth experiencing homelessness where perhaps you've had some success?
So HPI, we tried 2 pilot programs for housing prior to working with the health plans. So we spent a lot of money trying to figure out what would work for the homeless youth. So what we do is, I'm sure a lot of the community knows, we do mobile response for some of the health plans. So we touch base with the client when they're in crisis. So we see them in ERs, we see them in schools, we see them in parks, wherever the client is. If we get called, we go and see the client. And then if the client goes inpatient to a psychiatric hospital, we have case management that actually follows the client while they're in the psychiatric hospital. If they get discharged to HBI outpatient clinic. And from there, we collaborate with Blue Cross and Molina. We place these clients. We do intensive case management. We've had a huge success. It's been over 80% of people. We find them jobs. Some of them go back to school. Some of them go get Social Security. Some of them get better relationships with their families. But of course, it takes a lot of time, right? It takes a lot of time and effort to do those things. But we've seen great success. So I'm hoping we can expand it a little more. That's kind of like what we're hoping for. That's why I'm here today. I feel like even within our panel, like some people didn't even know what HBI was, or I didn't even know what some agencies were. So just the fact that we're all sitting here, we didn't even know about each other. So I'm hoping with all us being here, we can help the community,
In terms of, I guess, like things that are working. So what we are doing in Los Angeles and what my organization does, we're really coming from the systems-oriented kind of how to address things is what we're working on, and do a lot of policy advocacy. But one of the things that we really believe in is bringing young people into like the decision-making power of how the system should look like, right? So we, a couple years ago, in 2019, we actually had a youth policy summit, and we put young people into a closed room, 50 young people, and we're say, come up with the Homeless Youth Bill of Rights for Los Angeles, and what are the things that you want in the system or that you're frustrated with? And there's some things that came out of that I think we've even touched about before that, you know, I would have never come to that conclusion. And one was transparency and scoring, right? A lot of young people we heard, they're like, I was answering questions in this intake and I didn't know no one told me that was going to be for my score for my housing placement. I didn't know what these questions were. I didn't know what this was about. I don't know what score I got, all those things. And then later I find out that had to do, my whole entire housing path had to do with that one interaction that I had. And they were like, that's messed up. And then the other thing too is his right to refusal without consequence. You were saying someone just got housing placement and they refused it. They said, I don't want to live here for reasons that, you want to?
Yeah, so with Blue Cross and Molina, it's temporary housing until they can get a permanent solution. And we had one of our clients who actually got permanent housing and refused. They said the area where they were going to be placed they felt like it was setting them up for failure. So it was not a good area of town. So we actually tried to communicate with the agency that was trying to place the client, see if they could place the client somewhere else, and they did not want to. But it's very disheartening, you know, like when a client can advocate for themselves and say, hey, I am not going to succeed in this area of town. There are a lot of drugs in this area of town. And, you know, the funding is going for these places in this area of town. And, you know, the client can say, hey, this is not a good area. I'm not going to succeed. And they're still saying like, okay, well, you're off the list, you know? And it's insane. To me, it's insane. I think another thing too is with the queue is the person has to be homeless like for 1 year. Yeah. So that is so if we're talking about homeless youth, right? So you're just homeless and maybe we could just capture that person and give them a little help and hold their hand and they can succeed. They can even go to college. Like we have clients that are in college currently and they can do well, but it's like, nope, you can get help, but in a year. So how much worse is it going to be in a year, right? So why do we have that even in place? So things like that I feel like are just not very helpful.
Yeah. There's an advocate we work with and they say it's like it would be like a cancer patient coming and being like, oh, you have cancer, I'll wait till you have like a tumor and then we'll give you treatment or like whatever, you know, just stuff like that. When you're stage 4, come back and we'll give you resources. But so the right to refusal without consequence, that was one thing. They're like, I can say no to a house. If I say no, I get kicked back to the bottom of the list and I have to start all over. So those are just some things by bringing young people into, you know, actually asking them what they want, giving them some power to actually say what's wrong with the system and listening and responding to that, how important it is. And you know, what we continue to do now at my organization is we went from kind of that closed door room with bringing young people into that room for an hour. We now have, I now have 4 formerly unhoused youth working as full-time advocates, right? But with salaried positions, full benefits, but then alongside that, we have a full-time retention specialist, right? So actually the support and safety net that we have to provide for continues, right? And that work is really, really difficult, but also so important. And I think there's a lot of that we need to be pushing forward, right? If we want to kind of change a system that's more responsive and meets the needs of young people, is listen to them and put them in these rooms, right?
Dr. Durrett, maybe I'm wondering if you could speak to, you know, we're kind of hearing what can be effective on the homeless services side, which is prioritizing autonomy, flexibility, actually matching services to the needs of young folks. And then I think maybe something we can speak to a little bit more, which is how long and how intensively support needs to be maintained, right, in order for someone to succeed, you know, in terms of housing. But what about on the mental health side? What are you seeing be effective in terms of treating some of the higher acuity young folks?
So it's funny because the issues that impact the treatment of higher acuity individuals are no different than what you're talking about, which is having connection, ongoing support, ongoing services beyond the crisis. So I'll just give an illustration. Over at Mojave Counseling, which is the outpatient treatment clinic through UNLV, We have a very large cohort of individuals that are adults with severe mental illness that are in our treatment programs, and they receive what's called targeted case management. So each individual person is connected to a case manager who does things like go to their homes and check on them and make sure they have adequate food and clothing and bring them in. Sometimes we have a day treatment program. They can come in to treatment and to services on a daily basis. And it's extraordinarily intense. We have a cohort of 40 case managers for the patients that we see, and they all carry a caseload of anywhere between 20 and 30 patients. So you just think about and you extrapolate out the higher number of individuals. And these case managers do things like bring people their medications, bring them in for injections, sit with them at their psychiatry and therapy visits. And I can tell you through illustration, we have case managers that will follow patients for over 20 years. So recently, very sad, we lost a client, they passed away, and their case manager had seen them on a weekly basis for 17 years. And that person was maintained in housing for 17 years. And had that case manager not been there on a weekly basis, they would have ended up in the homeless system. And so on the one hand, yeah, like you mentioned, it's cost intensive to manage somebody successfully. But if you have that one person that an individual trusts and connects with that can follow them through the good moments, the bad moments, and support them consistently, we can keep people out of the system. And so that's something that definitely could work. And I don't know if that directly answered your question or not, but it was giving an illustration of like things can work.
Yeah, no, absolutely. That was perfect, I think. So maybe I just want to get Kim and Richard involved here. You know, we've heard about some things that can be kind of effective in adjacent spaces. I wonder if any of this seems like something that might be integrated into some of the programming that we see at NPHY or at Shannon West. You know, maybe how these approaches might be integrated, but also what the barriers are, because I know there are substantial ones, what the barriers are to doing some of this more intensive, long-term continuum of care type follow-up that integrates both mental behavioral health and probably also physical health as well, because we know, again, a lot of these more acute individuals have a lot of medical complexity as well.
So we're talking about barriers.
Yeah, barriers to integrating some of these more long-term continuum of care type approaches.
So I think the biggest barrier to integrating some of these services are funding. You know, who's going to pay for a full-time psychiatrist at Shannon West or NPHY? Our housing dollars don't pay for that. Some of our housing funding doesn't even pay to order birth certificates. And so funding is absolutely, I think, the number one barrier. But we also have to take a look at client choice too, right? If we integrate a mental health professional, is that the mental health professional that they want to see? Or is it just something, you know, that's there? Is it, and in Shannon West is a low barrier housing first harm reduction. So what that means is that, once again, I'm not going to tell you, you have mental health, you need to see the psychiatrist. Sometimes it takes our case managers months for them to even be open to look at that they may have some mental health issues. And then you mentioned medication, it's a wrap. It's over. They don't want to talk to you anymore. And so I think, you know, in our society, there's a stigma that's placed on people with mental health issues, right? Oh, you're crazy. Oh, you're never going to be anything. And so I hear it all the time. Are you saying, Miss Kim, I'm not crazy? And I'm like, I know you're not crazy, you know? But we, you know, and I think another barrier is like, we need to learn how to play together. You know, we need to learn how to support each other in our community, because this isn't, it's not my youth, it's not NPHY's youth or Richard's youth. This is our community youth, right? And we need, as a community, to support our youth. These kiddos are our future, right? And they've been thrown away. They've been dumped, and I think that I think we need to play together well, And how do we do that, And one of we're talking about solutions later, right? Okay. We can weave it in. Yeah. Okay, we can weave it in. Yeah. So 18 months to get a youth that is on the autism spectrum and the developmental disability system. It wouldn't cost us anything as a community for that system to prioritize people that are unhoused, right? It wouldn't cost us anything. There's some solutions, right? Embed people, that are students, right? Our reciprocity from other states to get licenses. Like, we need to fix that. We need to fix so much. I have a list. Resources like Vanessa was saying. I knew who Richard was, but I knew no one else on the panel, right? And so knowing who, where, and what services they provide, like, to everybody, right? Because these are our community youth. And so we need to serve them. It takes a village. And our village is separated right now. We need to come together as a community and work better to serve our people. These are our people. Okay, I'm done with my soapbox for the second.
Those are some very good points, Kim. Yes, absolutely. On that note of collaboration amongst the providers, that's key. And another thing that too, we have plenty of resources. We have the wealth. We have the innovators. We have the great minds that can solve these problems. It's about, making sure that we get that point across that this is urgently needed. This is a priority. This is something that we need to work together on to collaborate. And we all have to be unified amongst our interventions and our strategies when tackling these issues. Another thing, too, that I think we have to work through is the fact that a lot of our youth that come through the doors and they're seeking basic services, they're averse to even medical treatment. They don't obtain preventative medical treatment. So a lot of the youth that come through our doors are getting that for the first time, too. So add on top of that mental health with that additional stigma, it's another barrier for them to kind of work through. And when we're talking about things that might be working is the incorporation of the advocates and the peer supports, other people that are similar in age that have maybe had some similar life experiences or dealt with some challenging situations themselves and made it through. To be that kind of, exemplary example, basically, you can make it through to the other side, and I can show you how I did it. Those people that can be the conduits for that change, the conduits for that evolution, and say, I'm here, let's do it together. Yeah.
Yeah, I think these are great answers. Kim, you inspired me to get on my soapbox for a little bit, if people don't mind. Just, I think we were speaking to some of the, I think what's often described as resistance to engaging with case management, mental health care, stuff like this. I think it's, so important to remember that the great majority of youth and young adults experiencing homelessness have also experienced trauma of some form. I think, I don't know, when I was doing more direct service work or, when Robin and I did our intervention together, I don't think we spoke to any youth who had not experienced trauma, even if they said, no, I haven't. And then you ask about their background and it's like, oh no, that is a traumatic experience, what you're narrating. And so as a result of that, a lot of these youth may have been in a situation where no adult at all in their life has been validating and supportive. And in fact, adults and representatives of, systems, whether it's the justice system or school or mental health care, have been coercive and have tried to push back against the autonomy of the individual. And so I think those barriers, those trauma-informed barriers, are very real. And the only way to overcome those, and I think probably we would agree here, is with long-term, sustained, patient engagement that starts from a place of validation and care, right? That is absent coercion and prioritizes autonomy, even if we think like, I wouldn't make that decision, you know? So, you know, given that that sort of trauma background is pretty ubiquitous, I wonder if maybe we can think about what kind of supports, and I know we've spoken about this a little bit, but maybe kind of narrowing in a little bit, what kind of supports might be most beneficial in, you know, our kind of Southern Nevada context? You know, is that something like new housing models where there's a bridge between like full autonomy, your own apartment, and, you know, something that's not coercive, but that's maybe residential, where people can get a higher level of intervention? You know, is it some change to the queue? You know, it's my understanding that we don't have a public mental health organization, and that's something akin to, you know, the LA County Department of Mental Health, for example, where, you know, the buck stops there. You know, I'm not, maybe folks know more about that landscape than I do, but is there such an organization here that we might lean on?
So I'm glad you brought that up. LA County and every other county in California has their county-driven mental health systems. Many other states do. When I trained in South Carolina, each county, there were 3 counties in Charleston, each county had their own county mental health system. We do not have that in Nevada. We do have Southern Nevada Adult Mental Health Services and Northern Nevada Adult Mental Health Services. And these are agencies that trickle down through the Department of Public and Behavioral Health, but it's not the same as a county mental health system. And that's a huge deficit that we have in our state. And, you know, I'm sure that somebody who has practiced, I've only practiced in the state for like 17, 18 years. Someone who's been here 50, 60 years might know some of the history, but it doesn't exist. And typically a county mental health system is the end-all catchment for patients. You know, things that come out of county mental health systems are proper PACT teams, which I can't remember what a PACT team stands for. It's essentially something assertive community treatment. But that's where, as you were describing, you know, you were talking about it in Portugal, but we have this in other parts of the US, where a team of the psychiatrist and the therapist and the caseworker, we get in the car and drive around and go to people's homes and give them long-acting injectables or give them their pills and check in on them. Back when I did this, I met with people at a Waffle House. I went into people's homes. I went to somebody's backyard and saw them. It didn't matter. It was getting people the services they need. And there are some treatment models that have been proven for years that are effective. Another example is multisystemic therapy, which in the juvenile justice population, but in other high-risk populations like child welfare, is a system which is similar to a PACT team, where it's coordinated teams of psychiatry, therapy, case management, peer support, et cetera, that not work with the individual, but all of the other adult things around the individual, like the school, the environment, like if you live in the projects with maybe the gang leader in your projects, whoever it is, the church, the interventions are going around the person to catch them like a bubble. And that's an intervention multisystemic therapy was invented, I believe, back in the early 90s and has been proven in many countries to this day. And so, you know, I guess I'm going on a soapbox again, but it's the idea that there's things that work and we need them and we don't have them.
So this is a related but different way of phrasing. If you, what is your queen, king, or monarch for a day solution? You know, if you were in charge for a day, the budget was at your disposal, and you could make one or several big changes, and subsequent administrations had to maintain those, what would you do? What's your first move?
I have a soapbox. But I'm like stuck on the case manager for 17 years, right? And my current soapbox is about the crisis in labor, or labor crisis in the homelessness services and direct care services, right? And I said like that to think of a case manager right now that would be working with someone for 17 years. Like, are you kidding? No, that doesn't happen. You're lucky if you're at a place and you have someone that wants to stay there for a couple years, right, and work with people. We have such high turnover, and the way that impacts the care that's being given is just like, I mean, that's just one component of what like turnover means. And then right now, in Los Angeles, we have 2,000 empty positions in the homeless service sector. The jobs aren't filled, and people are not taking the employment, and case managers have already been strapped, and it's just beyond that. So it's like the levels of it is just getting worse and worse and worse. And if we don't address it soon, it's going to be a problem. So my, queen for the day is like, really, we need to be paying social workers, case managers, doctors. Yeah, like
will bring more people in.
High, like salaries equivalent to what law enforcement is making. People that are doing that kind of service. Yeah.
Yeah, I think it's such a great point because there are other organizations that have had problems hiring, like for example LAPD. I think their new recruits, no college degree, make around $60K a year before overtime, and they get a $20,000 housing supplement. Okay, so it's solvable. It's solvable, and it doesn't diminish, I think, people's passion for law enforcement that they get offered these attractive packages, right? It's just simply a reflection of the changing cost of living that also, incidentally, is driving our homelessness numbers. So, love that solution, Queen Robin. Thank you.
Well, here's my queen for the day, and my queen fantasy goes even above and beyond homeless youth, which is investing money in prevention services. I mean, how many times have I gone to panels and discussions where we talk about the problem. We can try to do things to actually prevent the problem. So investing in robust social emotional learning programs, starting all the way back in kindergarten, pre-K, in elementary schools, and infusing that all the way through. And including mental health screens at the earliest of ages, and then immediately getting somebody referred in for services, and doing what we can to really help prevent the end result. We're not going to prevent every case, but right now we're not doing a thing for prevention, and that is my fantasy.
I definitely agree with you. So, and I was sharing with you like earlier, so in Portugal, like people come to the schools and they talk about like homelessness and talk about drugs and talk about this stuff. And I was telling him, I'm like, somebody going to a 6-year-old, to a 6th grader and talk about drugs, the parents would, not like that, because there's this idea of like, if we're talking about these things, then they're exposed to these things. But if they're exposed to these things and they know about these things, then maybe we'll prevent them from doing these things later on. So, and I remember being exposed super young to these problems, and of course, like I don't do drugs and I'm not homeless, and all my friends are not in Portugal. So it's being exposed. I think it really does help. So I think education, that would be a big one. There's a lot of stuff that can be done, I'm sure. I think community, I think they're still today here. There's not like the community coming together. That's one of the biggest things that I see different in different countries, is how the community comes together to help everybody. And not family, it's not even somebody they know. There's like these, and I will talk about Portugal, but they do these festivals, and when you hear festival, you want to go, but the festivals are like, people will bring food, and it's people with money and people with no money, but everybody wants to go to a festival, and they just give food out, like, right? So they give like bread and meat and all this stuff out to people, but the community comes together, right? So it's like, how can we come up with an innovative way to bring everybody together to the same place where we can discuss these things and help them at the same time? I feel like that's what's needed here.
Yes, great ideas and great examples. One of the other thing I would add on to that is that, the funding and the pay is wonderful, but if we don't couple that with that like structured training, that support from the leadership to kind of work through these challenging issues and, just have that ability and that foresight to develop the teams that are supporting these youth, they could be getting paid as much as they want, and they'll still have that turnover issue. So it's really revisiting those models and those structures, like what is trauma-informed care, what is motivational interviewing, what is positive youth development, and then expanding upon that with all of these newest iterations of the challenges that we're seeing too. So that's another thing that I think would be another queen for the day, to fully support those workforce people coming in, to empower them as well to then pay that forward to the youth that they're serving.
I wish we would end youth homelessness so I didn't have to, so my agency would fire me and be like, Kim, we don't need you anymore because we ended youth homelessness. But what I really want is I really want some reputable group homes. I want, I have one right now. I want some place that those youth with SSI can go so they don't have to go into the adult homeless system. The homeless system is not set up for long-term use, right? And so I want some group homes. I want mental health professionals and psychiatrists embedded in all of our programs, right? I want to start talking at a young age, right? About what's going on in our schools, right? And identifying those young people so we can get them services and get them on the list before they hit it. Maybe a respite program for parents so they don't drop their developmentally disabled adult son or daughter off of my doorstep and say, hey, you take care of them, because maybe all those parents need is a break, right? I want us all to work better together, because these are our community youth, right? I think that's enough, Queen, for the day. That's a lot. I'm asking a lot, but it's something that we can do. Like in other states, my case managers from other states, they're like, yeah, I can get a client into California developmental system in like 72 hours. And I'm like, oh, man, we're not even close, right? And maybe it's because we don't have the infrastructure. I don't know. I don't know what their program looks like, but I know that 18 months is a long time for somebody with autism to sit in a homeless shelter, right? They don't do well. And then when they become violent, we have to exit them to the adult shelter. Our youth don't belong in the adult shelter. Half of them don't even belong in the youth shelter. They need medical interventions with people that know what they're doing. I can provide housing all day long. I don't know how to, that's not my specialty, right? Actually, what I want is I want to be out of a job. Yes. I want to go lay on the beach somewhere. Oh, Denise is right there.
I wish you could all be queens and monarchs for a day. This was all, these are great solutions. I think just to kind of bird's eye view and reflect a little bit, I think of what I'm hearing is kind of several things. One is we really do need this significant investment in mental health infrastructure so that we have a continuity of care of the type that you mentioned, where somebody can get in for crisis screening, get set up with a treatment team, and then they can be followed as they recover, and their recovery can be supported and maintained through lower levels of care, case management, maybe exiting the system, maybe not. Maybe that case management continues in the example you gave. And then it sounds like sort of a parallel investment is really required on the homeless services side, where, we might be able to put somebody into, like a rapid rehousing or in their own apartment or in a hotel room, but that's just not going to be an effective solution for everybody. And, it's a thin line, because we certainly don't want to go back to the 80s where people are warehoused and institutionalized, but it's not black and white. There are people who will do better with more intensive case management and treatment, and we ought to invest in and provide that for people. Am I hearing that right? And then I think, Vanessa, to your point, which connects to something Rob and I were talking about at lunch, there is just this, and Kim, you were saying this too, there is a community component to this. And by community, I mean, and I think you meant also, the real human caring side of things, where we look at people as valuable, even if they're difficult, and we commit to meeting their needs for as long as it takes for them to do well. And then if you commit to that, they often do well. So Rob and I were saying, well, who were the proto case managers? Like, who's the original case manager in your life? Most of us here have original case managers, even if we've never been in the system. And who are they? Your family and your parents, right? They manage the heck out of your case. At least mine did. I had intensive case management. And even that sometimes is not enough. But it goes a long way. And they do that case management for 17 years, 18, 25, 40, however long it takes. But I think, of course, not everyone has that. And even then, things can go wrong, right? But that level of commitment, most of those proto case managers don't have a huge caseload, right? What is it, like 1 to 5, something like that? And that's not easy. They're pretty tired. So I think the parents will understand this. So I think reorienting a little bit to that frame of mind, and then, finally, that doesn't come cheap, right? And I think, it would be great if, the world was different than it is and we didn't need money to make people's lives good, but that's not the world we live in, and we ought to pay people what they deserve for the work that they do, and it ought to reflect how important it is to us and to our community. So that's my little king for a day. So maybe we can think about, I think we're almost to our question period. Yeah, so just maybe last thing would be, if people have a recommendation for what action steps are most critical for interested residents, other providers, our elected officials, journalists, funders, other stakeholders, if there's anything like a key takeaway that you would want one or one segment of those folks to know or to think about.
Spread the knowledge, like what you've learned here today, pass it forward to your family, your friends, your community members too, so that they can also spread that. That's one of the main things too when it comes to outreach and raising awareness. That's one of the major components to it.
I would say that advocacy is really critical, and when it comes to things that are in the realm of the legislature, it all starts at home and in our community, and the more you speak up and connect with elected officials from, say, for example, the Clark County Commissioners to city officials, the more you speak up and share with them what we've talked about today and all of these needs, the more it's going to be at the tip of their brain, such that when the potential for legislation comes around that can positively impact the kids that we serve, they know to contact you and you can help walk them through it.
Yeah, on the advocacy, I think one of the things is ending youth homelessness is absolutely possible, right? And so committing to that and taking that into your advocacy mindset. In Los Angeles, there's 4,000 youth that are experiencing homelessness in our last count. That's a lot, right? But there's 70,000 people experiencing homelessness in Los Angeles County. So it's a sliver. Every day, we have young people that are graduating out of youth homelessness into adult homelessness, and that doesn't work. And then I have one stat, 1 in 5 adults in permanent supportive housing in Los Angeles were homeless before the age of 25. So it's like, this is a win. We can do this with the focus, and ending youth homelessness is prevention, right? And think of it's possible, right? So bringing people into that fight, in that commitment, and what we could do if we did that. So it's both the urgency, but also that this is a long game too.
Okay, so I'll touch base on, so you said something in regards to it is expensive, but it's also more expensive to keep people homeless, right? So if they go inpatient, if they visit the ERs, that is way higher cost than working on this and preventing this. So I think maybe that's kind of what we have to drill into everybody's minds. It's actually more cost effective to not have people being homeless than them being homeless. And So I'd say, yeah, that's the biggest thing that I can think of.
Thank you. Hi, I'm so glad we're here talking about this important subject. My name's Annette Mullis. I'm faculty member in the UNLV School of Nursing. One of my very favorite jobs was working at Community Outreach Medical Center, and we provided wraparound HIV care for individuals with HIV, but also we address like underinsured individuals, really vulnerable populations. One of the things you guys are talking about coming together, and then education also, Richard was saying. So we had these Ryan White grantee meetings on a national level. And so we would talk in our county with anybody who got grants from that particular grant. We'd have these meetings and they had strategic plans and goals. And then each year we would talk about where we got to on those strategic goals. So do we all have like similar funding agencies where we're getting money from, where we could get, tap into the national education for this?
Sadly, I do not believe so. I think we are all funded through myriad streams, none of which significantly cross, unfortunately.
Yeah, I was a teacher, so I can talk pretty loud. However, part of the issue too, and we're learning this within other systems, such as the homeless system, nobody owns this, right? So there's no one to go to, and I know you guys touched on that. So there's no end-all, be-all, right? There's nobody pushing that strategic plan, right? We can put together a strategic plan, we can put together goals, but somebody has to be accountable. We need one place to go and who can get those funders for the cause, right? That's the most effective way, it seems to me, that we could actually push a lot of this forward, and that right now that's not available.
Hi. I'm a UNLV nursing student here, and kind of to piggyback off of what you just said just now, going off of the resources, I wouldn't even know where to send somebody if they came to ask, hey, how can you help as a nursing student? And even to further that, I've been a first responder in the Valley for 7-8 years, and even having that as my background, we were always told, hey, they have caseworkers at the hospital, the nurses will help them. And now being in the hospitals as a student nurse, I see that that's not the case. So granted, I do take some personal responsibility because it is something I could also try to research, but again, I wouldn't even know what to research. I know, like you guys had mentioned, some of the areas we have in town, but to my knowledge, they're all adults, and like some already said, they're not super great. So just to piggyback off of that, we just need resources, more community education, because also, honestly, I only heard about this because of my professor. So I think that maybe if this was taken to another level and really pushed out to the community, more people would come, more people would want to help, because I'm sure there's a lot of people in the community that would want to. So yeah, that's all I got.
Hello, I have a question. How do you serve young people who have come through or are coming through the criminal justice system? Because it occurs to me that there's several layers of challenge for them. You got the trauma, which maybe led to the incarceration, and then you have the mental health problems. Is there any sort of special way that you address the problems with young people? I just happen to know someone who is currently incarcerated and will come out to many challenges, and so that's why I wonder, how do you serve people young people who are going through that?
So I can answer it through the therapeutic lens. Trust is really key. And the trust between the individual and their clinician, be it a psychiatrist, a therapist, whomever, the trust really needs to be the first step. You're not going to go anywhere if you can't have trust. And so how do you establish that? Coming to the individual that you're going to work with, your patient, with a non-defensive stance, to be very open, to share with them that your role is not to be part of the juvenile justice system, that you're there to help them, and that you're there to listen, and to take the time to actually empathically listen to somebody. And it takes time. I do not believe it happens in the first visit or the fifth visit. But if you can demonstrate to somebody that non-judgmental, compassionate, unconditional, positive regard and consistency over time, oftentimes you're able to build that trust and move things forward.
What about from the kind of the housing side, like, because obviously securing housing in the best circumstances is so challenging. So, someone who's coming out presumably doesn't have employment yet, is going to have to report their status on a rental application. Are there resources that any of our program folks know about or have that can help support somebody with that kind of extra level of challenge?
So we do take individuals coming out of incarceration up to our age limit, which is 24, and each person is evaluated on a case-by-case basis. We take into consideration maybe some of the work that they've done, why they've been in detention or in prison, the nature of the crime, a lot of interviews. And so that's a barrier that our homeless youth have, right? Because we have a lot of youth on campus that have criminal activity. And we take that on a case-by-case basis, right? Because breaking into a building for some place to sleep, that's a homeless crime, right? They shouldn't be, I'm not a lawyer in the legal system, but that's a homeless crime. Like stealing food, that's a homeless crime. Our people go to jail and prisons for that, right? And so each is on a case-by-case basis. And so we want to give them that same shot, because what happens is if we prejudge on criminal convictions, right, or even past criminal history, what's going to happen? They're just going to go commit more crimes because they need to survive, right? They're going to go rob somebody for some place to stay, or steal some food, and then we have this vicious cycle of criminal behavior. And so we do take individuals with a criminal background, and so,
Kim's correct too on that. With NPHY, that's how we kind of tackle it on a case-by-case basis as well. A lot of it also comes from shifting that focus from the judgment to the positive reinforcement, and including the team. If they are still systems involved, if they're on probation or parole, we'll incorporate that into the team as well, to kind of just focus on the progress that they're making with us, and shift the focus from maybe them carrying that around with them, and as it doesn't define them. They're moved past that. Let's assist them with moving past that too, removing any barriers, record sealing, things that we can assist with as far as that goes. Yeah.
Okay, and then I'll also add to that. So sometimes if they have an outstanding ticket, or sometimes they're scared of going to court, or so our case managers actually go to court with them. And what I found is when the caseworkers go, because they have a support system, usually they're more lenient with the person. So they'll say, hey, we'll check in with you in 6 months or a year, and if you show up, then your warrant is gone, right? So I think not just the fact that when they also leave jail or prison, we also service that community, but before that happens, we can assist them, because they're just scared of going. We just go with them, well, I'll go with you, we'll tackle this together. And because they trust, like you said, they trust the caseworker, they trust the clinician, the fact that they're going with them, it makes them show up. And it a lot of times prevents them from even going, to jail or prison.
Good afternoon. Thank you, panel, students and faculty. My name is Sergio, and I came today with my wife. She had an emergency. She has a practice here in Las Vegas. And I wasn't going to come, but I came to educate myself and be able to assist her and give her some of the information. And if I may, from a layman's term, or just a community member, right, everybody wants more money. But even if you had all the money, all the funding that you could, you don't have the support staff to do so. Share some information with us. My wife almost moved out of state to go to a school that she was accepted that would work with a working professional. The UNLV program didn't allow a working professional to actually participate and become fully licensed. So what can we do from a legislative, from a school scholar, right, level to assist in possibly having people pursue a career in LMFT, LCSW, because again, you need those people in the front line doing the work for the facility, the organization, et cetera. Thank you for that question.
Yeah, so I can speak to this in a little bit, and thank you for your question. I think you're absolutely right that it's so critical to remove barriers to our behavioral health, mental health workforce. I mean, we really need more investment, more support, and to lower those barriers. I will say, I'm in the School of Social Work, and we in the School of Social Work absolutely have many working I'd say most of our students are employed, and a significant number of them are employed full-time. And we have a number of kind of tracks that people can take so that they can continue to work, provide for their families, and also get their education and be prepared to be successful and get licensed. So at least in the School of Social Work, that's something we support. I think in terms of the legislature, there are some programs. For example, in Los Angeles, I was a beneficiary of this program where the LA County Department of Mental Health paid for my master's education in exchange for me working there for a couple of years. It was great, so I got my tuition covered and got great training at LA County Department of Mental Health. I think we have something similar for our Department of Child Services, but because we don't have a County Department of Mental Health, there is no analogous program. But some kind of support of that nature, I think, would be really welcome. So hopefully that speaks to a little bit of your question. Did someone else want to? No? Yeah, but if you want to touch base with me after about the MSW program, I'm happy to do that.
Hi, my name's Lori. I'm with the Nevada Resilience Project. I'm one of the ambassadors. My coworker, Ahmad, is over here. And what I've just realized, because I went back through my files of our resources, is we only have a handful of resources for youth. There's like nothing there. Like I saw yours, and I've seen others, but there's just nothing there. And how do I, if I have a youth caller or I run into a youth, how do I recommend them or give them resources when they're just so sparse?
There are 3 homeless providers in our county, and that is Nevada Partnership for Homeless Youth, St. Jude's Ranch for Children, and Help Southern Nevada Shannon West Homeless Youth Center. So, I mean, we are a pretty mighty of 3 agencies.
So one thing that I'll just give a shout out to a program that we run out of the Department of Psychiatry is called it's a Child Psychiatry Access Program. The website is nvpal.org. And somebody in the primary care setting can call that line or do a text and get a child psychiatrist on the phone, as well as a care coordinator who can help connect them with resources for anything in the mental health sphere. And it's a free service for patients 0 to 25. And by 0, that means we can catch parents who might be struggling with peripartum mood disorders. We did that on purpose to have the loophole to be able to catch those parents.
nvpal.org.
Hi, my name is Amalinda. I work, I'm a peer support specialist intern at NAMI Southern Nevada, and I work on the peer support line for Nevada through NAMI Western Nevada. And my question is for the third speaker from the right. I came in late and I missed your name. I'm very sorry. So my question is regarding the funding you were able to secure for your organization to employ 4 full-time homeless youth. I was wondering what the process looked like for you to secure this, and also if your organization is taking any measures to try to recruit new graduates or current students. And the reason I was interested in that was because I appreciated your discussion on compensation. A lot of my peers from school or coworkers end up leaving industries like mental health or social services because of compensation. They love the work, but they're not able to survive on it. And I'm 25 and I still live at home, and that's how I managed to do it. But I was just wondering how your organization was able to do that.
Yeah, thank you for your question. Yes. Well, it's like, I was just saying to Nick at lunch, we had lunch before. I don't know if you caught that. But yeah, we're kind of the only people doing this right now. And so there's not really a blueprint for this, and kind of figuring it out as we go, and how kind of talking about the challenges of it, right? And right now we're actually individually funded. All of our positions are funded by private foundations. So the Hilton Foundation, Cedar Sinai, and another family foundation. So it was private funders that have invested in this. But we started out, 4 full-time positions started out as a youth board where we paid young people $20 to come in and provide their input. That got raised to $30 an hour. That turned into short-term contract positions. And my first employee, Travis, he's not here. We hired him, and we hired him for 10 hours a week. And we didn't have funding for that. I was like, I will find it. And we put it together, and I was like, I believe like his voice is so important. What was happening is I was having these youth boards, and I would go talk to the youth board, and then I would go into this other room and say, this is what the young people are saying. And I was like, this doesn't make any sense. So Travis, come on, and you need to be in the room and speak for yourself and your peers. And it started just as that. And we did that, and we were there and brought Travis in to all these spaces, and he kind of shadowed me, and I forced him into all these rooms. Then that became people coming to us and said, hey, we want to do youth work. You guys know how to do it. Can you come along board? And that turned into 4 employees, full-time employees, and which will continue to grow. But the work that they're working on is building a fully youth-led intermediary. So the goal of the work and that they're advocating for is a youth-led organization that will be like dictating and helping redesign the entire system and keep the system accountable in Los Angeles. That's it's a long game, but we're already seeing how important it is to build these positions out and bring young people into the leadership here. And I'd be happy to talk more about it too. Yeah, it's a long game, and I think we need to be continuing to advocate for higher compensation. And I do think there's legislative things to explore. It's just we got to keep talking about it and stay on the soapbox.
I just want to, because ever since I've met Robin, you've always just been so passionate about making sure we pay youth for their time. So can you just give us the numbers? Like, what are they making, and what's their benefits like?
So they're making $65,000 a year with benefits, full-time benefits. That's living wage. It's close to living wage. Honestly, at this point, it's not in Los Angeles anymore. So we're going to do cost of living adjustments and things like that in the next, but they get, health insurance benefits. And then beyond that, right, then we had to incorporate into our organization. We have a full-time, I had someone coming on that was kind of, she was working as a program manager. And after 4 young people started, we quickly pivoted her position to be full-time, like a support staff. And so we call her retention and advocacy specialist. And her job, full-time job, is to make sure that they can stay in their job, which means she is navigating all kinds of crises. We're building out trainings. She's helping young people navigate how to get insurance and transfer into that. Helping young people find housing because, right, they get $65,000 a year. We had my employee got hired and she had her Section 8 voucher. Her bags were packed. She was moving. And 1 week into her employment, she lost her housing, right? And she has 2 kids and we had to put her up in a hotel for 2 weeks, right? So we've worked with our funders too. We've been really supportive funders that also believe in the work. And we said we need an emergency housing fund. So we have an emergency housing fund for all of our employees and youth contracted employees. That's $3,000 a year they can access for some emergencies. And they've all accessed it. Yeah. So I'm happy to talk about it a lot. And so in other spaces, yeah.
Hello. My name is Ray Sean. I'm actually with the Education Opportunity Center. It's one of the TRIO programs that's housed here at UNLV. So what we do is provide educational resources to individuals who are looking to get into some form of post-secondary education. So we start with the high school credentials and prep them for the high school equivalency exam or help them with obtain their high school diploma, documentation or whatnot. And again, navigating through the whole post-secondary education to include grants, scholarships, filling out their FAFSA, that whole nine. We actually have partnered with Shannon West. We actually go down there and do pre-testing down there and help the individuals actually prep for the exam. We also will pay for the exam and other actually community partners. I've also just recently met with individual for Employee NV. They have a new program they rolled out to help youth to where they actually incentivize them actually going into the workforce. So they have gift cards they give for individuals who go out and participate in a particular training program. They also incentivize it for the employers. Actually, they actually will pay the wage for the individual, provided that the employer actually will train them. They also give them funds for starting a bank account and different things of that nature. There's also another program that I just heard of that's for youth. I'm sorry, it slips my mind. But basically where I was going with it is there's these different programs out there. I know there's a shortage, disparity of programs for youth. However, the ones that are available, it seems that they're not being utilized to their potential. It's not really the manning. It's just the fact that youth or individuals aren't really using. They're being promoted, but they're not being used. So is there any advice to try to encourage the youth to use these different programs that can actually benefit them?
I think that's one thing we see often is that there are a lot of barriers to using programs. So we just started asking young people what the biggest barriers are from accessing some of the programs that, so we actually work with organizations and we do needs assessments and we ask, what are there programs that you want to use that you can't? Yes. And then we say, why? And the biggest thing is I don't have enough time and I can't transportation in Los Angeles. That's the thing. I literally don't have enough time to access the program. So I don't know. It's just kind of finding what are the actual barriers for not accessing the program. And it could be, lack of awareness, lack of connection. But for us, transportation is a huge, huge thing. So actually, when COVID came and more services became offered remotely, then that opened up a whole new area for young people to access different things. So there are creative ways, and I think it's just asking young people about those barriers.
Yeah, I think one more thing that we see happen often, and Vanessa, I think you kind of spoke to this, is anytime you give a phone number and there's not a warm handoff from one human being to another human being, the odds are very high that you're going to lose that person. And the odds get higher with the more other stresses and barriers they have. I mean, I know me personally, without that many stresses and barriers relatively, if somebody gives me a phone number for a referral, I'll call it once, and if I don't get through, that's probably it. So just imagine if you have these other barriers and stresses. So I think, you're describing going to the ER, picking somebody up, taking them to their psychiatry, taking them from psychiatry to housing, and from housing somewhere else with a human being. So I think that's the way that you ensure that someone who's interested in a service actually receives it, is by having a human being connect them from you to the other person. That's the warm handoff.
And I think one of the barriers, I'll just add to what you were saying. So imagine a person, we all have cars, but there's people that ride the bus for 3 hours to go somewhere that we're telling them to go. And they arrive and they're told, actually, today is Monday, come Thursday at 8 a.m. It's what? They're there now, So that happens so frequently with so many agencies. And that's one thing that I do pride myself, HBI, you come in, we could be closing at 6. If you're at my door, I'm going to see you, Because I know that it's so hard for them to even go and ask for help. So to get there and say, well, we can't help you today, we can't even help you tomorrow. So, it's very discouraging. So I think maybe, I don't know, I think someone going with them, at least it's like you're there with them, you're supportive, okay, well, they're close today, we'll come back Thursday together. I think that does help. But if a person is riding the bus and gets there and there's, no service provided, it's very discouraging.
I want to just last question, and panelists, if we could keep our ends collectively maybe to a minute or two for this, so we can move on to our final component. But last question. Saving the best for last.
Hello, my name is Ahmad. I'm a member of the Nevada Resilience Ambassadors. I am a crisis counselor. I've been in the field for 4 years now. I've been a case manager for 3 of those years, and 1 of those years I have been a rapid rehousing specialist. I have 2 questions. My first one is a rhetorical question. What can we do about the zoning laws that restrict low-income housing in every area? There are a lot of those, and I would encourage everyone here to look at the zoning laws in your area and challenge them if you can. My main question for the entire panel is, what do you think about teaching children the basics of psychology at an early age? For example, understanding and processing emotions. And do you think it is as essential as math and science is? And if it is, how can we go about getting the Department of Education involved?
Well, your question touched on my fantasy. I don't know if you heard about it earlier, but I have a fantasy that on a preventative side, we bring social emotional learning to kids as young as pre-K. I absolutely believe, and it's not just like the Lisa belief, but there is a ton of research and data that demonstrates that if you look at a cohort of kids that have gone through social emotional learning curricula and those that didn't, the kids that had the curricula have less disciplinary actions in school. They have less risk for engaging in substance use, et cetera. I mean, these are core skills of how to solve a problem, how to mitigate conflict, how to de-escalate within themselves. I think I'm pretty blessed. My kid goes to a school that actually has been teaching this. And I remember all the way back in preschool, she was given lessons of okay, so you're stressed, so we blow up a big balloon and we blow out the balloon. And little things like that then build in the curriculum as they get older and older to teaching how to stay away from substances, how to make good, healthy decisions, how to identify psychiatric crises and mental health crises within your peers, within yourselves, and deal with it. So, yes, I think it is critical.
You have something to say, Robin?
Just real quick.
Oh, yeah.
Not only do we have to treat the kids, but the parents. We have to treat the parents also, because if that's a perfect world, right? We get these kiddos good in school, right? And they go and blow a balloon up at home, and the parent screams at them and pops their balloon. We've just undid everything that we do, and that's one of the things why the youth homeless system exists, is because we have children with parents without coping skills, and they teach children no coping skills.
Well, I'm sorry to have to cut off Q&A. Sometimes, we worry there's not going to be enough engagement after a panel, and then other times we have to cut off the engagement, so I'm sorry. But can we get one big round of applause for our panelists? So our hope for you today was to kind of learn more about this intersection, understand that you aren't alone in some of your questions and struggles with this intersection, but also that way we could learn about things that we can do both today that maybe don't require more money or resources, whether it's new partnerships we can form, new ways to approach our clients, learning about new services that maybe even amongst this panel we didn't know exist, because I'm definitely in that boat too. But not only do we want to talk about those things, but we also want to talk about things that we can actually change in the future, and whether we need to bring those things online to our systems, whether we need to do more or less of something or prioritize something. So I will touch on this again in a minute, but I just want to that to someone's point about how can we get more of this discussion and more people here, that is exactly what this platform is trying to do, is trying to create these type of discussions and be the bedrock for them and have them actually extrapolate out more into the community. But we know that some people that needed to be here couldn't be here, but we also want our commissioners and legislatures and policymakers and stakeholders and public and private funders, et cetera, who also aren't here to learn more about this. So we're committing to making sure that between UNLV and the movement that we create some sort of research reach after to not only capture this discussion, but also hopefully further it into next steps around action or ideation. So we'll be doing a research brief, like I just said, and I'd like you guys to take out your phones, or if you still use a calendar or whatever, so you can save this date. November 8th, it'll be the Nevada Youth Homelessness Summit, which will be, the venue will be at the Smith Center for the Performing Arts. Registration opens in August. However, we have a sign-up sheet right outside so you can kind of get in line. So we'll do that. And then I want to congratulate everyone on completing the Movement Institute Volume 3 on mental health. For those of you who are attending today for the first time, you can pick up your Be the Movement pin, which I was wearing until it got too hot, at the registration table on the way out. And please wear it proudly. Please share this discussion. Please sign up for our email list so others can come as we explore other topics in future Movement Institutes. I don't have my phone to take a group selfie, so we'll just do that later. Yeah, that was on the notes. But real quick, the work doesn't stop here. It's now up to you to continue the momentum of change. We need you to share what you learned today, like I just said, with your friends, family, coworkers, decision makers in your community, everyone and anyone you can, to take action and to be part of the movement to end youth homelessness. Because being part of the movement to end youth homelessness is also being part of the movement to solve some of these other issues that we're seeing in our community that intersect with youth homelessness. Definitely mental health, juvenile justice, we can go on and on and on. But we want you to visit our action center in the lobby, because every time we do a Movement Institute, even though it's a training, we want to have some sort of action that happens afterwards, so each of you can be mobilized to do something as well. And we have an add to our What's Your Why board, so we can understand what's your why you're here, why you're invested in the issue of homelessness. I want to take a second to talk about writing a letter to our Clark County Commissioner. So I have an idea. Maybe we should write our Clark County Commissioners and ask them why we don't have a Clark County Mental Health Center, or maybe to fund a Clark County Mental Health Center. And I think that the more people that write, and think about it, it creates employment, permanent employment for our community. It can actually pump out, future Dr. Bars and other people here through education investment. It can create necessary resources for vulnerable pops, like we talked about today, that necessary backstop. It will improve our overall community health, and it will save precious public and private dollars that can be reinvested in the long run. So maybe we need to write our commissioners about something as specific as that. So that's just an idea. However, I'm sure many of you have things that have sparked that you can write to your commissioners and let them know that you feel pretty strongly about, and that's our hope. And if you want to learn more about youth homelessness or being part of the movement to end youth homelessness, or make suggestions about our movement and what we could be doing differently or better or whatever, there's an anonymous suggestion box. Well, it doesn't have to be anonymous. You can sign your name, Meg Pike, and just say whatever you need to in our suggestion box. And lastly, please sign up for our email list so you can learn more about these type of events and learn about our summit that is going to be coming up on November 8th again. So thank you, everyone, and congratulations to all of you for being part of the movement to end youth homelessness. Thank you again to our esteemed and wonderful panelists and our wonderful hybrid panelist moderator role for Dr. Barr, so thank you for that as well. And we will see you all in November or sooner. Please visit our Action Center, and hold on. Oh, yeah. Sorry, I thought that was all going to be explained there. So the Action Center. So we actually have information out there so you can, do QR codes, I believe, or some way to... Why don't you guys come up and explain this?
So Arash was talking about writing to your commissioner. You don't have to remember this and go home and look up your commissioner's address. You can do this right now in the lobby. So that's what. So we have, if you go in the corner where all the high boy tables are, we have postcards and we have addresses of all the Clark County commissioners and their names and their districts. We have postcards available out there to do that. So if you want to do that today, you could write as many as you want, right? Like several ideas, etc. But yeah, whether it's a department, whether it's a center, whether it's other stuff. But yeah, so you can do that today before you leave, so you don't have to do it later.
That's a wrap, people. Thank you.